I'd like to thank everybody for coming to Health Watch USA's meeting, where we're going to hear a quick synopsis of experiences from around the world with the COVID-19 pandemic. I think this is going to be a very insightful meeting because of the Omicron variant, which is emerging around the world and starting to increase exponentially, although still small numbers. It's increasing exponentially in the United States. And so I'm very happy and pleased to have this meeting and to have a number of notable speakers who are willing to give their time and their experience to tell us about the situations in their country. So the first speaker which we will have is Dr. Sebastian Hoehl, who's a pediatrician and a virologist at the University Hospital in Frankfurt, Goethe University. He's been leading investigations on SARS-CoV-2 transmission, and early in February 2020, he was one of the first, if not the first, to identify and report asymptomatic spread of the virus. So at this time, I would like to introduce Dr. Hoehl.
Yes, thank you very much for the kind introduction. Welcome, everybody. Over the next about 10 minutes, I'm going to give a brief overview about the situation that we're at in Germany and the measures that are currently taken against the pandemic, and only brief remarks on Omicron because we don't have much experience yet. So I'll start the presentation with a graph with data that you're probably very familiar with, is the incidences, the infections, the daily confirmed COVID-19 cases per million people in the United States, where infections in the last winter reached very high numbers. And if you compare that to Germany during that time, which was actually quite mild, there were not so many cases when you compare it to the United States. But the last couple of weeks, we've seen a big Delta variant-driven surge of infections with really high infection numbers. And this is not homogeneous throughout the country, but there are certain areas where this wave sort of started, especially in eastern and southern Germany, where numbers are much higher than in other regions. In the north, the border to Denmark, infections are much lower at this point. And of course, the important question is, how are we set up for this? How's the vaccination rate? How much severe cases should we expect? And globally, of course, we have an extremely uneven distribution with very, very high vaccination rates in some countries, such as the United Arab Emirates, Cuba, Portugal, and we have very low rates, especially in Africa. In Germany, we're only right there in the middle. So we have high vaccine availability. Pretty much anybody who wants to get vaccinated can get vaccinated. Headquarters of BioNTech, who created the vaccine together with Pfizer, is just around the corner from here, but we still only have 72% vaccinated and 69% fully vaccinated, which in this context means just 2 doses. About 25% have received a booster at this point. And that means we're still seeing considerable numbers of patients in intensive care. And this is a very useful graphic. That is a register where intensive care units provide how many cases of COVID-19 they're currently treating and what the capacity is like on the bottom. And we currently have quite high numbers of cases, almost 5,000 in the country. But the big problem is that the capacity is the lowest it's been in this pandemic. So that we only have a report of about 1,500 beds available in intensive care, which of course is a very unfavorable position now that we're expecting another surge on top of the Delta surge because of the Omicron variant. And the usage of ICU beds at the moment also very geographically unevenly distributed, with especially in Eastern Germany, many patients being treated with COVID-19 or being transferred to other parts of the country. And this, of course, at a time where the country is also is a lot happening in politics. We've just a couple of days ago had a new government. Angela Merkel left as Chancellor of Germany after 16 years in power. And now we have a coalition, which we call the Traffic Light Coalition, of the 3 parties, and the new parliament just passed an amendment to the Infection Protection Act, which enables some additional measures to be taken. But which measures are actually implemented, again, comes down then to the states in the federation. In our state here of Hesse, I want to give you a very brief overview about what kind of measures are being taken. In most indoor spaces, masks are mandatory. And also in most crowded spaces outdoors. In schools, students are being tested 3 times a week with an antigen test, but in kindergarten, there's usually no testing occurring. For the other measures, it's good to learn 3 words in German that I sort of want to teach you tonight, which are geimpft, genesen, and getestet. These are the 3G. So these mean vaccinated, recovered, and tested. And so measures are usually split into 3G, 2G, which then only refers to vaccinated or recovered, geimpft or genesen. And then we have 2G plus. This means if you want to attend or if you want to get allowed to get into this environment, you need to be vaccinated or recovered, but also tested and not or tested. And then it can be very confusing to see which of these actually applies in which scenario. At the moment, in most workplaces, 3G applies. So that means you have to be vaccinated or recovered or tested on the same day. In public transport and in universities, at the moment, we have this 2G, which means that you cannot attend if you're not vaccinated or recovered, but also not attend if you're being tested. Refers to places such as sports facilities, massage parlors. The symbol here refers to museums and most places shopping other than essential shopping. And then we have the 2G plus in places like nightclubs and also venues with more than 100 people. And here we have a bit of a new development because to get people to get boosters, the government just announced that people who have received a booster shot of the COVID-19 vaccine don't have to be tested anymore, even in a scenario where testing has been mandatory before. And this is causing a lot of criticism because this is a very inopportune time to drop testing requirements for vaccinated, because we've already seen that Omicron can also spread between people who have received a booster vaccination. And this at a time as we're also seeing first cases of Omicron, but we're also seeing a very sharp rise in neighboring countries such as Denmark. And also, of course, we're now just ahead of Christmas, where usually people in Germany like to gather at Christmas fairs like this one in Frankfurt. And it's a very large concern because, as I mentioned earlier, especially since now expecting the Omicron wave, we're at the lowest ICU capacity we've been at any time in this pandemic so far. So in the next couple of weeks, we have to expect the surge and pharmaceutical intervention. And of course, booster vaccinations are important at this point more than ever. And this concludes the presentation.
Our next presenter will be Professor Imogen Mitchell, Clinical Director of the Australian Capital Territory COVID-19 Response and Executive Director of Research and Academic Partnerships, Canberra Health Services, Canberra, Australia. Dr. Mitchell is one of the top experts in Australia, and we are very fortunate to have her presenting tonight.
Great, thank you very much. So yes, I'd give a short overview of the Australian experience. As some of you will be aware, that Canberra is actually the nation's capital. It just happened to be situated between Melbourne and Sydney. I suppose what I'll start first with is the strategies that Australia has taken forward during COVID. I think there has been strong political leadership, which has originally, up until very recently, driven by science. And there certainly was very little tolerance for COVID surges that would then lead to increase in the number of deaths. There have been extremely strong public health teams. Some were a little bit weaker to start with. As you can appreciate, Australia is a federated country. And so that the jurisdictions have had their own public health teams, have been advised by the Australian Health Protection Committee, which is the national body for providing advice in terms of COVID experience, so that the public health teams have been extremely effective. Once they were adequately staffed, have really done an enormous amount with tracking and tracing, quarantining and testing. The public health strategies have been legislated, and that has meant very early on, from March, the international border was closed to try and minimise traffic of those coming in with COVID. Indeed, anyone coming in from international travel would have to go into 2 weeks quarantine. And that has certainly diminished the amount of COVID that has entered the country. I guess after 18 months of closed international borders, it feels quite restrictive. And so about a month ago, those international borders were released. One still has to quarantine for 3 days if you're vaccinated coming into the country. There was also obviously lots of public health measures, which included reducing indoor gatherings. There were multiple lockdowns, and I think Melbourne, unfortunately, has the sort of celebratory greatest number of days in lockdown throughout the whole COVID pandemic. We've also had tracing mechanisms by having to enter data into an app, such that when you enter shops or restaurants, that your details are provided so that the public health teams find it easier to trace people if there's a known COVID case. I think what's been very interesting, literally in the last few weeks and even yesterday, there's been the release of public health measures, so that certainly in New South Wales, which is the biggest jurisdiction, which has about 8 million people residing in it, that they're now losing the QR codes to enter restaurants and supermarkets. And I think people are quite concerned by that, having got used to a way of life of entering these data. And now that we're starting to see a surge in the number of COVID cases. So as I mentioned before, the international borders are now open, and there is now a reduced effort, if you like, of mask wearing. As you can see, Australia's really had very little in terms of the number of cases. This is actually the actual number per day of cases, so it's not per million. And so you really could see that we probably never got above 2,500 in any one jurisdiction. It's going to be very interesting when we start to see what happens with Omicron, because even today I've just noticed that New South Wales has got 1,800 cases, and it was only at 1,300 yesterday and about 400 the day before. So there is no doubt that Omicron is here and doubling their numbers each day, almost. You can also see, if you look at the total number of hospitalizations amongst the jurisdictions, again, has been quite low. And so whilst New South Wales, during our so-called second wave, which was through August and October, whilst it was under pressure, it was really only under pressure in certain parts of Sydney. So I don't think we've yet to experience an overwhelmed healthcare system, neither from hospitalizations to ward beds or to the intensive care environment. I think what's going to be interesting is that about half of healthcare in Australia is delivered through the public health system, which is where we've seen surging in terms of staffing, and the other half is actually delivered by the private sector. So it's much harder to corral their support, although again, that can be legislated through our public health measures. I think the big question for us is that we're just opening everything up, literally. So domestic borders have been removed pretty much, although Western Australia still won't open its domestic border or indeed its international border until February next year. And so I think Omicron is going to be very interesting, particularly as we've got a, unique experience. If I look at my own jurisdiction, was the Australian Capital Territory, we have a total population of about 460,000. New South Wales, I say, is about 8 million. You can see the vaccination rate. So if I look at my own jurisdiction, we've got 12 years and over vaccinated, and then 98% fully vaccinated. So from a Delta point of view, we actually feel that we've got herd immunity. I think what's going to be interesting is that what actually happens with Omicron. The other jurisdictions surrounding the Australian Capital Territory, New South Wales, and again, they are about fully vaccinated at 93%. So they've just opened everything up, same with Victoria. So is that actually going to impact case numbers? I think more importantly for us is whether it's going to actually minimise the number of hospitalizations with Omicron. You can see jurisdictions that have not had COVID, so South Australia, Queensland, Northern Territory, and Western Australia. They are a little less vaccinated, and I think the concern that we all have is that there is probably a greater Indigenous population who are likely to be frail, and so are less vaccinated, which obviously is a major concern to us all. Having been a very slow starter from the vaccination status, we had real access issues to supply. Australia is actually now very well vaccinated, and particularly on the eastern seaboard where I currently reside. So I think in summary, Australia to date has been reasonably well protected. We've had closed our international borders until quite recently, and I think time will tell as to whether Omicron actually starts to stress our healthcare service, which I think will be of great concern for many. So I'll stop there, Kevin.
Well, thank you very much for a very interesting presentation. Our next presenter is Dr. Matthias Maiwald, who's a senior consultant and the head of service microbiology at the KKK Women's and Children's Hospital, and an adjunct associate professor at the National University of Singapore and at Duke National University of Singapore Graduate Medical School. So at this time, I'd like to turn the presentation over to Dr. Maiwald.
I'll be giving an update from Singapore in December 2021. The overview is on this slide. Singapore is a tropical city-state with about 5.5 million population, and the current total cases are about 270,000, close to 280,000. We have about 6,000 active cases currently. We have 789 deaths so far, and the rate of death in Singapore is among the lowest in the world, which stands at about 0.3%. The ICU occupancy currently with COVID cases is 32 patients in ICU and about 567 cases in the general wards. That is as of 11th of December. I'll also go through the current pandemic measures that are in place in Singapore. So the public measures are mandatory mask wearing outside the home for all people above 2 years old, access to shopping malls only for vaccinated people, and there is a mandatory Trace Together app or Trace Together token. This is either a smartphone app or it is a wearable token that registers entry, etc. And it is mandated for entry at public places and shopping malls. And it is checked in, and it serves both for checking the entry and for contact tracing if someone comes into contact with infected cases. The dining currently at food outlets or restaurants is in a maximum group of 5, and only for vaccinated or accompanying children of less than 12 years of age. The maximum number of household visitors is currently 5 per day. And for any performances or congregations like church services, concerts, etc., is capped at 1,000 people and all must be vaccinated. There are certain allowances for people who are tested. Travel is possible in the form of vaccinated travel lanes. Singapore has vaccinated travel lanes with selected countries, for example, Germany and the US. And the vaccinated travelers do not need quarantine, but they need to be tested before departure and after arrival up to 7 days. That is a mixed regimen between PCR testing and antigen rapid testing. The arrivals from all other countries that are not in the vaccinated travel lane need quarantine, and the duration of quarantine is depending on the category of the country. For us healthcare staff, since June 2021, we have a rostered routine testing for all staff. It was first done by PCR, and currently we are all tested twice weekly by antigen rapid tests that are self-administered. Okay, so I'll show you in this slide the Singapore timeline in 2020. And so what you can see on top is the different pandemic phases that Singapore has implemented. And then you can see 3 what we call epicurves of imported cases, community cases, and dorm residents. Now, the dorm residents is probably something that is unknown to people from other countries. The background is that Singapore has a reasonably sizable population of foreign workers. Often these are people from low-income countries, for example, construction workers from countries such as Pakistan, Bangladesh, Myanmar, and so on. And what was experienced was in April 2020, there was an outbreak in the dormitories where these people were accommodated. And what you should notice on the left is that there are different axis scales. So for example, if you look on the bottom with the dormitory residents in 2020, they were the most cases. Then I'd like to share again with you, I've already shared this in a session in June, the respiratory virus infections during the first year of the pandemic, which we find very interesting. So if you look into the background of this slide, you see the gray bars are the number of tests performed at 3 different hospitals from which we got the data. The tests are the multiplex respiratory virus tests, and we looked at a lot of different viruses, influenza, enterovirus, rhinovirus, RSV, adenovirus, and so on. And what you see here, if you look on the right in the year 2020, is that influenza A and B disappears first. And the general assumption is through all the travel restrictions, contact restrictions, pandemic measures, etc. And then during and after the lockdown, we had a near complete disappearance of all respiratory viruses. And in late 2020, some respiratory viruses, for example, enterovirus/rhinovirus, reappeared. Okay, so I'll go into 2021 here on this slide. So this shows you the Singapore timeline up until December 10, 2021. What you see on top of the slide is the different Singapore phases that were implemented. What you can see from the different colored bars is that Singapore went through a few different phases because of the epidemiological situation. Essentially, there were unexpected circumstances in Singapore that made the government implement different phases. So on top, if you see left top, at the beginning of the year, we were in reopening phase 3, and then we had to go back to phase 2, etc. And so there was a little bit of toing and froing. Again, what you see on the slide is imported cases, community cases, and dorm residents. And the dorm outbreaks were largely contained by late 2020, but there is a flare in October 2021, if you look at the bottom. But what dominated 2021 is the community cases. So if you look at around April, May, we had a case spike with a Delta variant, we had an airport cluster, hospital cluster. And then if you look at the right side of the slide, we had a massive Delta wave, another one starting in September 2021. The highest recorded number of cases in Singapore was 5,000 absolute cases per day. And if we look up to now, I'm having the numbers for 10th of December, 5 Omicron cases, 3 travel associated, 2 in airport workers. And as of this morning, or actually yesterday, it has increased to 16 Omicron cases, of which 2 are in airport workers. So Singapore currently is coming off at the tail end of a massive Delta wave that has swept through Singapore and is currently cautiously being contained, I would say. So next slide, what is the Singapore vaccination status? The vaccines under the national vaccination program in Singapore are the Pfizer-BioNTech vaccine, the Moderna, and the Sinovac. And if we look at the vaccination data as of 10th of December, 96% of the eligible population completed vaccination with 2 doses, and that amounts to 87% of the total population. And Singapore has started to roll out booster shots, and so far 30% of the total population have been reached. Here on this slide, we have a few other vaccination facts. The eligibility is for all citizens, free and permanent residents and long-term residents, age above 12 years. Booster vaccinations are now extended to all individuals over 18 years old and 5 months after the primary series. Childhood vaccinations have just been approved in a few days ago, the Pfizer-BioNTech in a pediatric dose is approved for children 5 to 11 years old, and it is currently prioritized children with medical conditions, and then subsequently it will be for all. Singapore has an interesting arrangement with medical care bills, and the background is that Singapore has a system of government subsidized healthcare with some residual pay by the patient. Yeah, so it's not a fully paid for healthcare system, so there is always a residual pay by the patient. And before 8th December, all COVID-19 related costs were fully paid by the government. And after 8th December 2021, all people who are unvaccinated by choice, meaning no conditions preventing the vaccination, will pay part of their healthcare for the usual government subsidized system. So for example, if they have a case of influenza or if they have a heart attack, etc., that will be the same reimbursement status if they are unvaccinated by choice. However, the fully vaccinated will continue with free care for COVID-related conditions. Okay, I would like to make some remarks in the last 2 slides about why WHO skipped 2 letters of the Greek alphabet in naming Omicron, which is interesting. So first we look at a WHO document from 2015 that said in the naming of new human infectious diseases, place names and people names should be avoided. And then another announcement from May 2021, whereby WHO announced a simple, easy to say label for COVID variants of interests and concerns, and that used the Greek alphabet. And this is from an article from CNN. It says the health agency skipped new along with a letter after that, Xi, and instead went straight to Omicron, the 15th letter of the alphabet. New is easily confused with new, and Xi was not used because it's a common surname, the organization explained in an email statement to CNN. And WHO best practices for naming new diseases suggest avoiding causing offense to any cultural, etc. groups. Now, the Greek letter Xi bears a similarity to the Chinese surname Xi, as in the Chinese leader Xi Jinping, and that was fueling speculation that that may have played a role in WHO skipping the name. But let us look at this slide. How is the Greek letter pronounced? And that's interesting. Now, Xi is pronounced as a KS sound, such as the X in English, such as the X in fox or box or socks or fix or taxi, and not as in boss or loss. Unlike, very unlike the S pronunciation of Xi Jinping. And I looked up and listened to YouTube guides to Greek pronunciation, and it is very clear that the letter Xi is pronounced with an X sound. And so in essence, the jumping of the 2 letters is based on a mispronunciation of the letter Xi. Okay, over, and I'll conclude my presentation. Thank you so much.
Thank you very much, Dr. Maiwald. That was an extremely interesting and informative presentation, and I'm sure it will spur many, many questions, especially on the financial incentives which your country has instituted. All right, our 4th speaker is Dr. Patrick Palmieri. Dr. Palmieri is a global health expert from Peru. He co-led the formation of the largest healthcare delivery system in Peru and is an associate editor of 4 leading medical journals. He also was one of the main drivers behind Peru's transparency initiative during this pandemic. And so at this time, I'd like to turn the floor over to Dr. Palmieri.
This is a very important meeting because I think it's very important for all of us to gather to talk about the realities of what's happening in different parts of the world. And I want to let everybody know that in Peru, we have a wonderful health system according to what the government reports officially. But the problem is what actually happens within the country is not always so good. So let me start by saying our country in Peru, we had 2.2 million confirmed COVID cases. We've had 201,000 confirmed COVID deaths. We've seen our second wave pass, And we seem to be slowly approaching a third wave as we see the deaths per day going up to like from 10 to 20 to 30, and the cases going up that are confirmed from like 60 to 90 to 120. I mean, we're seeing the trend again. Majority of our cases are Delta cases. We have not seen Omicron yet in Peru. There's some debate about whether there's been a confirmed case or not in Loreto, which is a very a distant province, but nothing confirmed yet. We also have Gamma and Lambda in our country, and those seem to be increasing in prevalence. Right now, our population, we are at 60% full vaccination, 70% with at least one vaccination. And then we have 5% of our population with the third booster vaccine because we've just started giving boosters. We have children 12 years and older receiving vaccines now, but we've not implemented yet from 5 to 11. So we're waiting for that. That's why we came back to the United States, my wife and I, so we could vaccinate our child who's 8 years old, because we don't want to wait. One of the problems that we have in Peru is we had no oxygen in hospitals. We literally ran out of oxygen because of the corrupt situation in the health system. Many things don't exist in the health system that should have. For example, there's lots of durable medical equipment that was supposed to be in hospitals. They weren't there because of corruption. It was purchased according to paper, but not present in the hospitals. So now we're building oxygen plants in multiple different hospitals. So now we have oxygen at least. So when we approach a third phase of the COVID, as I call crisis, it's not a pandemic for it, it's a crisis, we may be able to manage in the hospitals. One of the problems that we have in Peru is people are wearing their masks. We have a requirement by law now that we need to have at least one mask N95 or two masks that are not N95. We're no longer having to wear the face shield like we used to. But the problem that we're having right now is people are not really paying attention to the rules. I mean, in our country. So people are reopening their restaurants. And when we reopen the restaurants, it's just like in Miami here. In Miami, we have this huge problem with many folks. I mean, the restaurants were incredible in Miami. There were just all these different people like crowded upon each other, nobody wearing masks. And that's kind of what's happening in Peru right now. So one of the situations that we really are struggling with in Peru is that we have all the public health policies in place, but people are not abiding by the policies. In terms of travel, Peru is kind of locked into the policies of other countries for travel. So for example, to travel to the United States, within 24 hours, you have to have a negative COVID test. You also have to wear, obviously, your mask. You have to be vaccinated with two vaccines, two doses. If it's a Pfizer vaccine, if you had the Chinese vaccines, you're not going to be eligible to travel to the United States. Interestingly enough as well, may be the case in Peru very soon that we'll have to have the third vaccine before we can travel to the United States as well, as an example. But the thing I want to leave with everybody, it's very interesting hearing the different folks from the other countries talk about the reality of their situations. But what I want to really emphasize is the fact that on the ground in Peru, I mean, we have like third world conditions in our hospitals, and we have like third world conditions in the way the population is really dealing with this crisis. We're having political instability right now, as we have a communist president, and we have marches in the streets, and people just are very, not really paying attention to what they're wearing with their masks and being very close to each other. So I just want people to understand that what we watch on the news in many cases, for example, in Peru, is remarkably different than what's actually happening on the ground. And hence the reason why my wife and I decided to escape for a little while, because our daughter needed to be vaccinated. So thank you, Kevin, for this opportunity to talk about what's going on in Peru.
Thank you very much. Very interesting presentation, and very glad you could spend some time giving us this quick update. All right, our final presenter for the night is Noel Eldridge. Noel is someone who I've known for many, many years. He's a policy analyst in healthcare, and Noel is by far, I think, one of the sharpest people to analyzing data and summarizing what's going on in the United States. So at this time, I would like to hand the floor over to Noel.
Okay, thank you, Kevin. First thing I want to say, you can see the note at the bottom of the page that although I'm a federal employee in the United States, I've been working for the federal government for 21 years. This is just my personal presentation and my personal opinion. A few years ago, I gave a briefing on this Health Watch group, and it was on the topic of catheter-associated urinary tract infections. And I kind of wish I was giving a briefing on a topic like that right now, because it's a lot less scary topic and a lot less harmful than this current situation that we're in. Kevin and I have spoke for many years about hospital infection control, patient safety, and related topics. I've been working in patient safety primarily for 20 years, including for 10 years with Dr. James Bajan, who I invited onto the call and I think is also on the call today. Oh, last point is that what I say right here at the bottom, all this information is from public sources such as the New York Times, Stat News, COVID Act Now, so forth. None of the information in this briefing is from any databases that I have access to or had access to in different parts of my job since COVID started. Just to let you know, I spent 60 days detailed or assigned temporarily to the COVID response from March to May earlier this year in 2021. So this is my overall summary of the situation here in the US. And I would say overall, the response has been very bad. I figured there'd be some people on the call for whom English is not their first language, so I would try to speak very clearly. The US response has been very bad. In summary, you can see we're at 800,000 deaths, give or take a few thousand, and 334 million people. That's 1 in 418 people dead from COVID in this country. In comparison to other English-speaking countries that are close to this one, Canada and Jamaica are both around 1 in 1,200. So they're doing about 3 times better than we are. As an aside, I have connections to those countries because I was born in Canada and my father was born in Jamaica. So you'd be better off in Canada or Jamaica than you would be in the US. Also of interest is Canada's colder than the US and Jamaica's warmer than the US. So that also bounds it in terms of the weather, people staying indoors, people being outdoors, people using air conditioning, all the other things you might talk about. Both sides of the US are doing much better. So why has the US response been so bad? I think the first and foremost reason is the former president of the United States, Donald Trump. It's a disaster. And not just him, but his appointees that did a horrible job. They didn't do what needed to be done. And so that's why our response is 3 times worse than Canada in my mind. There's other reasons, but I think they all kind of rotate around that one. Now, what's going on in this country since then is a little bit more complicated and not as good as I would have hoped for in the last 10 months or so, or 11 months now. Well, more specifically, what's been bad is that we've had a lack of widespread and consistent indoor masking in this country. As our friend from Peru spoke a minute ago about Miami, many places around this country, people are essentially acting as if COVID doesn't exist, indoors and outdoors. And it's feeding the ongoing pandemic in this country, especially since the Delta variant hit. Another thing that's maybe unique about the US in comparison to some of our other wealthy countries such as Singapore, Australia, Germany, UK, not on the call today, obviously, but although they do have a nationalized system in the UK, when people don't worry about cost, so maybe it's not that important, but at least in the US, people do worry about cost and are sometimes reluctant to present for care due to fear of high costs. And you hear this from people anecdotally. I don't know if it's been studied numerically. We've had few organized testing programs, and we've had no easy access or low cost access to home tests. I bought a home test the other day. I bought a number of them. They're about $12 each in this area. It's $24 for a pack of 2 tests. So for me, that's affordable. I'm not worried about it. But for some people, they might make $12 an hour in a job in a supermarket or something, or in a fast food. They probably don't want to spend $12 for a test. And then lastly, this goes to something I said earlier. I would say another reason is bad advice from good people at important times. So first and foremost thing that comes to my mind on this was Anthony Fauci's advice that we don't need masks, which is a disastrous mistake on his part. It drove me crazy at the time, and I was trying to do something about it in the bowels of the Department of Health and Human Services, Agency for Healthcare Research and Quality, where I worked at the time. But I was totally unable to get any attention on the topic of increased need for masking. At the end of the talk, I'll give a very brief mention of why I kind of had a strong feeling about this from the beginning. And then another piece of bad advice from good people at an important time was just as the Delta wave was starting in June in the US, some people were pretending it wasn't happening and saying basically, it's okay, we can go back to normal, which was a disastrous mistake in June and July of 2021, in my opinion, because cases and deaths really went up a lot in the late summer. Next slide. So we've had a lot of different waves in this country. How you define them is imprecise. From my eyeballing this data, it looks like we have had 6 waves or peaks of different heights and different places. The first peak or the first wave, you can see I have 5 different states on this chart. 4 are the most populous states in the country, which are California, Texas, Florida, and New York in that order, with Florida being in red, California being in orange, Texas being green, and New York being in blue. And then I added a 5th state. It had its own little wave, and it's geographically apart from these other 4 states, which are kind of spread around the continent, which is Michigan, which is kind of in the middle and on the Great Lakes. And you can see that the first wave was the famous in the US wave featuring New York City and New York. And so that was where the first big peak was. The next big peak was in the summer. And you can see New York, for example, basically had extremely low cases that summer of 2020. It's the blue line at the bottom. And Florida had a peak there, but it wasn't a severe peak. The y-axis here is the cases per 100,000 rather than the deaths or anything like that. This is just cases. So New York is probably underrepresented in the beginning because testing was so limited in March, April timeframe. And then we had a big wave last winter, which started in November. You can see the purple there. Michigan started early and kind of ended early. It was kind of over in January. But if you look in California, they were peaking in January. So that winter peak was spread out, but pretty much everybody had that winter peak last year. And then, strangely, there was another peak in the spring in March, April, May, and that was focused in a few areas of the country. Michigan and Minnesota in particular had very high rates in that period. I guess that was the alpha wave, but for some reason, the alpha variant didn't hit most of the rest of the country. You can see some states had a little bump there, but a lot of states did not. And then, as I mentioned before, we had a huge wave that was starting out in June and going into July, and then went all the way through September, October. And if you look at the Florida data, the red line, it peaked and then it came down. But if you look at the purple line for Michigan, it's been going up since July, essentially. So the 2 last peaks have kind of blurred into one peak in some states like Michigan, but have been 2 separate peaks in some other states that you might see in the near future. So it's been quite confusing to try to understand these different waves and ripples around the country. I'm going to give you a couple of more slides here on these different processes that have occurred around the country. So here's 2 states that are right next to each other, Michigan and Ohio. This is from the COVID Act Now website, as the previous one was. This is Michigan and Ohio. These states are two next to each other. Michigan has 10 million people. Ohio has 12 million people. Demographically, they're similar. They're similar in many other ways. But the weird thing is, when Michigan had that big wave last spring, I was expecting it to go into Ohio, but you could see they almost had nothing in Ohio. And then in the summer, they both started late in terms of the Delta variant wave, and Ohio peaked higher at first, then came down quite a bit, and then Michigan just kept going up gradually, and now Ohio's going back up again in a second sort of Delta wave, which has been quite perplexing, I think, and confusing to try to understand what's going on. This is another pair of states, California and Arizona. They had a pretty similar situation. They both had very high peaks last winter, and these are not the coldest states in the country. These are 2 of the warmer states by and large. So the fact that it was winter, and by and large, people in Arizona and California are not staying indoors because of snow and ice and so forth, like Minnesota and Michigan in January. So it's a little bit surprising that it was so bad there in the winter. And then you can see in the recent data on the right-hand side, California's kind of survived the Delta wave pretty well, and Arizona has done maybe not quite as well. These are the two states that I lived in during this period. I moved from Virginia to Maryland during this period in May, and Maryland and Virginia really haven't had the worst of it. They've been two of the least affected states, I guess, in a sense, in terms of never having had a catastrophic wave. You can see here the high point on this scale is about 60. The high point on this one was 120. The high point on this one's around 100. So we've had kind of a milder waves here, and we've kind of just been percolating along at a pretty medium rate. Like, for example, last summer we were higher than New York, but we've never had any peaks as high as New York. This summer, we've had a second wave here, and you can see it died down in October, November, and now it appears to be coming back up. The point of this is it's very confusing state in our 50 states. I didn't show all 50 states, obviously. I showed probably about 10 states here, but I went through them to try to give some good examples of what appears to be going on. It's quite confusing and difficult to comprehend. Now, all these states have different policies also. If you look at Virginia and Maryland on this slide, for example, Maryland has had some pretty stringent masking requirements since August in the most populated part of the state. In fact, the counties have different rules in the state of Maryland. So where I live in Montgomery County, Maryland, which is right outside Washington, D.C., we've had a mask mandate for indoor situations since August 4th. Virginia has not. I was in Virginia this weekend, and you could go into shops and so forth without wearing a mask. You can't do that in Maryland. And that might be part of the reason why the rate kind of flattened out in Maryland and didn't flatten out in Virginia. Next slide here. This shows the deaths, the top 10 states by death per 100,000. For a long time, it was New York and New Jersey being number one and number two, and New Jersey being number one, actually, and then New York being number two. And then over time, this has changed. The two states with the highest death rates presently are Mississippi and Alabama. These are not two prosperous states, and they don't have the highest ratios or the best ratios with respect to doctors and hospitals per person and so forth in the country. So in some ways, it's not surprising that Mississippi and Alabama would have some of the highest death rates. They're also some of the poorest states. And also, you can see by the vaccination rates in the far right column here, some of the least vaccinated states, they're both under 50% fully vaccinated, whereas the country is 61% vaccinated, fully vaccinated at this time. The phrase at the top is from the Mike Osterholm podcast, which I listen to pretty much every week. He's an epidemiologist at the University of Minnesota, and he gives a podcast every week where he goes over the data and the information as he sees it. And he often says that his crystal ball is covered with mud because he's having a very hard time trying to predict what's going to happen. And I think that's the case for just about everybody looking at the US situation. Also of note on this chart, as you can see that these states, if you look at them on a map, they're spread out all over the country, everywhere except the West Coast of the United States. So from Arizona in the West to New York and New Jersey in the East, to Mississippi, Alabama in the South, Louisiana, and then Oklahoma, Arkansas, West Virginia, some of the states that are landlocked in the middle. None of the northernmost states, I guess, are on this list other than New York. New York's the only one of these states that, for example, borders Canada. This is an interesting slide I took from the Times on Monday. And this is showing that 75% of the deaths in this country have been in people 65 years old and older, which is, I guess, not surprising. 3/4 of the deaths have been in 65-year-olds and over, because we've seen that older people seem more prone to becoming infected, and they seem more prone to dying from the infection if they do become infected. Interestingly, it hasn't been that flat. Since the vaccines started to roll out in this country in January and December, you can see the rate started coming down for the deaths in the over 65 population. So here, for example, in December, it looked like about 80% of the deaths were in 65 plus. And then down here, September, October, it was down to about 60%, which is quite a large change if you think about it. And here I got put in yellow my own conjecture as to what might have happened here. These are hypotheses to ponder. Did this go down due to widespread vaccination in 65 plus people? The country is 61% vaccinated overall, but in 65 plus, it's much higher than 61% vaccination. So you might think here, the vaccination prevented the older people from getting COVID and therefore prevented the older people from dying from COVID. Whereas over in this side, I would start to speculate that the people that got it first are having their vaccines wear off first. Also, another thing is my own note right here about the Delta being so much more contagious is Delta finding the unvaccinated 65 pluses that the previous wave couldn't find. It couldn't get to those people. But now with the Delta wave causing so many more infections and so many more people, is it somehow sneaking its way to the unvaccinated 65 pluses and maybe also some of the vaccinated 65 pluses that are having waning immunity. But I think really the bigger factor is the one that I mentioned there first, these unvaccinated 65 pluses being found in the more recent period, so to speak, being found rather than during the earlier period where they could hide because Alpha and the other variants were not as contagious. This is another chart from the New York Times. It's, I think, a fascinating chart. It shows how many days did it take to have 100,000 deaths. So you can see that in the beginning it was 89 days to 100,000, 118 days to the next 100,000. So this is in the ballpark of 1,000 deaths a day in the country. Then it was 83 days, which is also a little, maybe 1,200, 1,100 per day. And then this is last fall into the early winter. And then the major wave happened in the winter. And you can see here from December to January to late February, it took only 36 days and 34 days to have 100,000 deaths. So people were dying at 3,000 a day in this period, okay, which is quite extraordinary. Then it went down to 114 days, which is the largest gap yet. This was February to June. This is when people started to declare some light at the end of the tunnel, and down to 900 a day averaged out there approximately. And then it was the next section again was 107 days, a little bit worse. Now, when this chart was made, it was 71 days to 95,000 more deaths. So, it'll be under 80 again, I guess, by the time we're back to the next 100,000. So I guess the question is, this 80 is going to be very similar to the 80 back here last fall, 83 days. So I'm hoping with all the vaccinations we have, even with the Omicron variant, we don't have two of these terrible months coming up where it was 3,000 deaths a day. But you might wonder if that's going to happen again. Personally, I don't think it is, but I don't think anybody knows. This is a piece of data that I took from a report from the state of Texas. It was a very interesting report where they looked at their cases from January to October of 2021. And you can see the blue line here is the cases in the unvaccinated patients, and the red line is the vaccinated patients. And these are the case rate. So this is basically how many cases per 100,000 people. So you can see here, it's 100 cases per 100,000 people in this period. And it's maybe about 10 per 100,000 in here. Now, the interesting thing that they focused on in this report is that this period here from September to October, 13 times as many cases in the unvaccinated than in the vaccinated. And we've seen similar numbers to this in many reports. But to me, I thought the interesting thing, in addition to everything else, was this bump here. This is flat here, like the vaccinated population is indistinguishable from zero on this chart with this scale. All of a sudden, it stops being indistinguishable from zero here. So this is, to me, a little bit worrisome. This is potentially a sign of that waning immunity that people are looking for. And then this is some of the key findings from the Texas study, the 13 times more likely to become infected. The unvaccinated were 20 times more likely to experience a COVID-related death, and the vaccination had a strong protective effect in people of all ages. This is the fine print here about the details. And then also an interesting finding was that the Delta variant seem to be increasing the rate of COVID by 4 to 5 times in that later period, comparing August to April. Okay, and so this is as of Monday, 2 days ago, when I made these slides, Monday and yesterday I made these slides, Monday night and yesterday morning. You can see the Omicron variant was starting to spread in this country. In this case, Washington State. Sometimes you see things earlier in this country, the places where people do more testing. I think Washington State, which is the state that has the city of Seattle in it. Seattle was one of the early states to identify COVID, was one of the early cities to see COVID in the beginning. So I wouldn't be surprised if they're seeing the Omicron variant earlier than some others are seeing it, or at a higher rate than others are seeing it, because they're looking with more intensity. I don't know that for a fact, but that's my kind of educated guess on that topic. Another thing I wanted to mention is this is a surprisingly good source of data. These are 5 screenshots off my cell phone. I have the app. Unfortunately, it's behind a paywall. I don't know how much you can get for free, but The Atlantic magazine has got some excellent articles throughout the period on COVID. Some of them are written by physicians, some of them are not, mostly written by science writers, but this is one that I think was very provocative on the end here. The pandemic of the vaccinated is here. I think we are in store for a lot of cases among vaccinated people, mostly because of the waning immunity situation and people not getting the booster shots that frequently. My last slide is just a personal comment. You see here on the box is this a little box with the date 2007 on it. That's the manufacturing date for 200 surgical masks I bought in, I guess, 2007 or 2008. They've been in my basement for 13 years or 12 years because back then I was working on a flu prevention programs for the Department of Veterans Affairs and the veterans hospitals in the United States. And I became quite worried about the chances that there would be another flu pandemic. So as I said, I had 200 surgical masks in my basement that I intended to share with family and friends in the event of a flu pandemic. I actually found another 150 N95s in my attic last spring. I had forgotten about them. They weren't in my basement where I knew the surgical masks were. And I have some of those too, and I gave many of these things away. The other thing you see there with the blue light glowing is an ultraviolet device that I also bought around that same time. I was convinced that flu was airborne and that if somebody in my house had pandemic flu, my wife or child, I was not going to run screaming from the house. I was going to put that device in the room and wear the masks and do the best I can to try to take care of them. Luckily, we haven't had that kind of pandemic where people had to take care of their own and not even go to healthcare providers. That's pretty much the end of my talk. And last thing I wanted to just mention is a website here. It's got a tremendous number of posters and educational materials that are good for flu and other pandemic signage and things like this, hand hygiene, respiratory etiquette, and so forth. They're all available free from the US government with no copyright. And they've been widely disseminated around the country and maybe around the world in the last 10, 15 years since we developed them. So they may be of use to you in your programs. Some of them actually in Spanish too. So that's it, Kevin.
Well, thank you very much. It was a very interesting and informative presentation. I'd like to now share with you a few additional items. One is a letter from Dr. Stephanie Dancer. She is a notable infectious disease expert from the United Kingdom. And I asked her to present and she was unable to, but did send a very short update, which stated, what I do know is that the Omicron variant is increasing exponentially. And despite initial reports saying that it causes less severe disease, the sheer number of transmissions means that the most vulnerable non-vaccinated are going to end up in the hospital. This is a problem because we are already full, and the whole is complicated by the fact that there are increasing numbers of healthcare staff at home self-isolating. So neither do we have the beds nor the staff to attend them. last weekend, but one, I was on call and had to close 2 wards, not because of COVID, but due to norovirus. Winter pressures always include this virus, and now there are reports of flu A from England causing problems in hospitals. We have yet to see this, but we usually follow the trends here in Scotland. The pandemic is far from over, and the ramifications will be picked over for years to come. So I think that there's a huge problem with the Omicron variant in that people that are trying to say, well, you know, it's something that we don't really have to worry about. I don't think is something that is going to really be a viable plan. I do think that we have to worry about Omicron, and I think it is imperative that we start to prepare. One of the items, and I'm sharing my screen which shows this, is that I looked at the vaccination rates, and I took these little graphs from the New York Times site tracking COVID vaccinations. And this compares the vaccination rates in the United States to that of South Africa. As you know, there are a number of reports that state, well, if you have a 2-dose Pfizer vaccine, you should be protected 70% from hospitalizations. Well, this data is coming from South Africa. And as you can see, the South African vaccinations have largely occurred within the last 5 to 6 months. In fact, most just within a few months, compared to the United States, where most of our vaccinations, especially of the most frail and elderly, occurred early on in 2021. So I am very concerned that if we do not pick up our rate of boosters, that because of vaccine waning, we are going to see a significant hit from this Omicron variant. Yes, it may be responsible for 1/3 less hospitalizations compared to last year's variant. But when you have a virus that's maybe 2 to 3 times or more infectious, that number then becomes much greater, and an overall stress on our healthcare system may be one that just isn't sustainable. So I think we may be in trouble here. We need to encourage vaccinations. We need to encourage getting boosters. And those were some of my final thoughts. At this time, let's open up the floor to questions. Well, one of the things I wanted to ask was on the presentation from Germany, if Dr. Hoehl is still on the line. They're 5 hours ahead, so this is getting quite late for him. If he is still on the line, on whether or not the definition of natural immunity or those that have had an infection, how exactly do you define and determine that? I mean, do you have a national healthcare system and criteria? Do you include asymptomatic infections? What exactly are your criteria for that? And also, how long from the infection is it still efficacious?
So as far as the regulation is concerned, when you have a PCR confirmed infection, whether or not you have symptoms, then you have 6 months in which you are equivalent to somebody who's fully vaccinated, and after that you would have to get a booster. The Virological Society said that probably immunity after natural infection lasts longer than that, but that was again before Omicron, where there might be concerns about reinfections occurring earlier than that. So, but as far as the government regulation is concerned, PCR positivity will give you 6 months of equivalency.
Well, thank you. And thank you for staying on. I think it's about what?
Oh, it's the middle of the night. It's
yeah, 1 a.m. or so at any rate. And also there was a presentation comment from Singapore, Dr. Maiwald, if you're still on. You had talked about testing of individuals. And I wanted to make sure that when you talked about testing of healthcare personnel, that also included vaccinated individuals, correct? I mean, we're tracking those individuals with testing also.
Yes, most of the healthcare staff are vaccinated, and even those who are vaccinated in healthcare are required to do twice weekly ARTs, or antigen rapid tests. Self-administered, we send the pictures to one person who witnesses it, the pictures of the antigen rapid test results. And then we have a certain website with an interface where we document the results, and then they are uploaded on a central server. Yeah, so it's all documented here. And the unvaccinated healthcare staff, there are very few left. They would have to undergo daily testing even. So it's a bit of a challenge for those who are unvaccinated, but there are very, very few left.
Okay, well, thank you very much.